Welcome everyone to the first case of the week for the new year. Welcome to January 1st, 2012. Hope everyone had a great new year. We're going to kick off this year with a really great case. This case was sent to me by a friend and educational expert, Dr. Chuck Werlow. He's a clinical professor of emergency medicine and is one of the faculty at the emergency medicine residency program in Lehigh Valley out in Pennsylvania. And he actually took care of this patient. Fortunately for the patient, Dr. Werlow was taking care of him. We'll talk about why. This is a 25-year-old male smoker, diabetic, who presented to the emergency department out there complaining of some dull pain in his chest. Now here's a patient that has no prior history of some wacky congenital problems, really no other major cardiac problems in the past. He's not using cocaine or methamphetamines or any other drugs that we need to worry about. He came in, he got a quick 12-lead EKG at arrival, and hopefully at this point what's already jumping out at you is the presence of ST segment elevation in a bunch of anterior leads. He's also got a bit of ST elevation in the lateral leads. So, gosh, is this a 25-year-old who's having an anterolateral Stemi? No way. Can't be possible. But anyway, when you've got a young person who comes in with ST elevation, you've got to think about other things besides a Stemi. So let's take a look at the differential diagnosis for ST segment elevation. And here's a rather broad differential, and this includes ST segment elevation causes not just in young people, but in older patients as well. And this is a good differential to always think about when you see ST segment elevation. It's not 100% comprehensive, but it's what you've got to think about at the very least. Let's start at the bottom. Brugada syndrome, we can probably knock that off the list. Brugada primarily only produces ST elevation in leads V1, V2, maybe V3. And this patient, as you recall, had ST elevation in a bunch of other leads. And Brugada syndrome also generally is going to be in a patient presenting after syncope or near syncope. And then finally, Brugada syndrome pretty much always produces this incomplete or complete right bundle pattern with ST elevation in V1, V2, and V3. This patient doesn't have any evidence of a right bundle pattern. Sorry, my artwork is really bad there, but that's what a Brugada pattern ought to look like. So let's get rid of Brugada. We can also get rid of ventricular aneurysm pretty much based on history. Aneurysms are going to occur in people who have had a previous big MI. And this patient has no prior history of a big MI, so you can probably knock out ventricular aneurysm from this list. There's no evidence of a left bundle or pacemaker. Also, a 25-year-old really is not going to have ST elevation due to left ventricular hypertrophy, and so we can probably get rid of LVH from this list as well. Young people can have high voltage or large amplitude QRS complexes, but that's not LVH. We'll talk about LVH on a different installment. But young people, generally, we don't use the 12-lead EKG to diagnose LVH in patients under the age of 35 or 45. We'll talk about LVH some other time. So that leaves us with this nice differential of four things: Stemi, early repolarization, pericarditis, and you've always got to keep myocarditis in your differential. Anytime you see any EKG abnormality, myocarditis is certainly one of the great imitators that you must keep in mind. So let's talk about early repolarization to start with. Well, first of all, one of the defining features of early repol is that the ST elevation must be concave upwards. It should not be horizontal, and it should not be convex upwards like a tombstone. All right, and in fact, if we just go back to the original 12-lead EKG, yeah, there is some concave upwards ST segment elevation in a bunch of these leads, but you know what? If you take a look at lead V4 and V5, I'm not too happy with seeing that horizontal ST segment elevation in those two leads. So that's making me kind of doubt whether this is early repolarization. And then the other thing which really makes me nix the diagnosis of early repolarization here is that if you go down the list just a little bit, there really should not be any ST depression in a patient who's got early repolarization. If you go back to that original 12-lead EKG, once again, what do you see in the inferior leads? There's ST depression in those inferior leads. And so for all intents and purposes, that really rules out the presence of early repolarization in this patient. You are allowed to have a little ST depression in lead AVR in early repolarization, but you really shouldn't have ST depression in other leads. And there's a few other things that we can talk about some other time. And again, Here's a blow-up view of leads V5 and V6, and you notice that the ST elevation appears to be somewhat horizontal, and that's another way, as we mentioned, of kind of disputing the concept of early repull in this patient. Early repull is very common in young people, but you've got to follow those rules that we just talked about. What about acute pericarditis? Well, pericarditis, just like early repolarization, is only allowed to have ST elevation that's concave upwards. It shouldn't be horizontal. It shouldn't be tombstone-like. You are allowed to have some reciprocal ST depression in lead V1 and AVR, but just like early repull, you shouldn't have any reciprocal ST depression really in any of the other leads. And once again, going back to the original 12-lead EKG, there is that ST depression in 2, 3, and AVF, and for all intents and purposes, that pretty much rules out pericarditis. Okay, so let's get rid of pericarditis from this list as well. So what does that leave us with? We've gotten rid of Brugada, aneurysm, left bundle, LVH. We've gotten rid of early repull and pericarditis because of the ST depressions in the inferior leads, and that leaves us really with two possibilities. Could this be a STEMI or could this be myocarditis? Well, two very reasonable possibilities in a young person. And how do you tell the difference between STEMI versus myocarditis on a 12-lead EKG? Very simple. You can't. The only way to tell the difference between these two entities is in the Cath lab, not on 12-lead EKG. These are very difficult to distinguish clinically. Both can produce concerning chest pain. Both can give you ST elevation with reciprocal depressions. Both can produce normal troponins or markedly elevated troponins. You can't clinically tell the difference between these two unless you're lucky enough to have a person coming in with fevers and clear-cut viral symptoms, and that might make you think more likely of myocarditis. That wasn't the case here. So, fortunately, Dr. Warlow said this patient has to go to the Cath lab, and when they took this 25-year-old man with chest pain to the Cath lab, what did they find? A 100% LAD lesion. And it was very fortunate that a smart person was taking care of this patient, because a lot of people would say, well, 25 years old, can't possibly be a STEMI. Let's think about some other possibilities. It would have resulted in delays, and it could have ended up resulting in a dead 25-year-old. So fortunately, they weren't misled by his age. They took the patient right to the Cath lab. And I just briefly want to talk about acute MI in young patients in just a minute or two. Please remember, this is the major takeaway point from this case, and the reason why I wanted to present this. Please remember that acute MI can and does occur in young patients. In the United States, 5 to 10% of MIs occur in relatively young patients under the age of 35 or 40, 45 years old. And these are not necessarily cocaine related. Only a minority of these are related to cocaine or other wacky causes. Acute MI in young patients is common, and it's becoming more and more common. And here's a study that you really ought to know about. This is from 1993. This is even before the current high-fat diets were very prevalent. This is an autopsy study of over 100 patients, average age 26 years old. Okay, so these were over 100 patients that were victims of inner-city violence. They got autopsies, and these patients, average age 26, what did they find at autopsy? Well, shockingly, 3/4 of them had significant atherosclerotic changes. 20% had multi-vessel involvement. 9% had more than 75% narrowing in at least one vessel. Average age 26 years old. Please do not rule out the possibility of a true acute coronary syndrome and STEMI just because a patient is young. It's much more common than we've previously recognized. And again, this study is from 1993. This is a number of years before the high-fat diets became almost popularized and routine amongst many of our patients. And a lot of the peds cardiologists are predicting that we're going to be seeing more and more and more teenagers with true STEMIs. So be very, very careful. Thankfully, Dr. Warlow was not thrown off by this patient's age of 26. He took a look at the 12-lead EKG. He appropriately ruled out all those other possibilities and said this patient has to go to the Cath lab even though he's only 26, and fortunately the patient ended up doing well because of it. So that's the first case of the year. I hope this is helpful. And again, don't discount ACS just because of a patient's age. Best wishes for a great 2012, and I will talk to you next week. Take care.